Welcome to Omnicurus Originals. We are celebrating the Diabetes Awareness Series, and today we have Dr. Surendranath Swain with us. Dr. Surendranath Swain is the present chairman of RSSDI Odisha chapter. He has a rich experience of many years serving his patients as a diabetologist. He has led many research and is currently working on microvascular complications in diabetic retinopathy. We are very pleased to have him today with us. Welcome, Dr. Swain. The stage is all yours. You may please begin.
Today, starting the microvascular complications of diabetic retinopathy. And the diabetes is very much common in our country. And the microvascular complications of diabetic mellitus is nearly three varieties, that is diabetic neuropathy, diabetic retinopathy, and diabetic nephropathy. And so today we'll discuss about diabetic retinopathy. So in diabetic neuropathy, the foot is involved, and there is sensory motor and amyotrophy and autonomic neuropathy. And in diabetic nephropathy, there is the KW nodules are there, thickened GBM is there, and the mesangial expansion is there. And in diabetic retinopathy, we are going when page by page because it's a very great subject. We will first go on introduction, then we'll tell about the epidemiology and incidence, then what are the risk factors producing diabetes retinopathy, and what is the pathogenesis, and how do we classify it, and how to screen diabetic retinopathy, and how to manage, and what is the treatment. We'll go one by one. So, starting the introduction of diabetic retinopathy, diabetes, it is one of the great problem in our country, and in 2025 it may be the diabetic capital of the world. And diabetes, it is the main cause of blindness among patients aged 20 to 74 years, and the patient usually present with blurred vision and come to a ophthalmologist, then ophthalmologist seeing the darkroom examination and by ophthalmoscope and other examination he does and find out a retinopathy and send for diabetic examination. Most of the people with different presentation of diabetes symptoms, the physician first see the patient, then send it to the ophthalmologist for a routine checkup of the eye, and they find out also diabetic retinopathy in some patients. So early detection and management of diabetic retinopathy can prevent blindness. Commonest category attending retina clinic, it is around 36%. Out of 1100, 400 are due to diabetic retinopathy. About the magnitude of the problem, about 32 million people in India, 6.2% of population have diabetes. It is estimated that 79 million people may be affected by 2030. In India, prevalence of diabetic retinopathy is 5.6 million. Most of them, about 5.1 million, are mild or moderate, non-proliferative type. Prevalence of diabetic macular edema is 5%, and CSME, critically significant macular edema, is 2.4%. In the West, prevalence of blindness due to diabetes mellitus is 1.6 to 1.9 per 1 lakh of population. So what are the risk factors? The duration of diabetes. The diabetes is diagnosed before 30 years of age, and the incidence of diabetic retinopathy after 10 years becoming 50%, and after 30 years it becomes 90%. So the duration of diabetes is directly proportional to the disease progression and progressing to diabetic retinopathy. Type 1 rarely develop retinopathy within 5 years of onset. 5% of type 2 diabetes have diabetic retinopathy at presentation, because any patient of diabetes type 2 on diagnosis should be routinely examined by an ophthalmologist, but not in a type 1 case, because in type 1 case have retinopathy after 5 years of onset develops. But sometimes in diabetic mellitus in type 2, the patient present in a late phase to the doctor, then we immediately send the patient to the ophthalmologist to exclude any diabetic retinopathy. After 20 years of diabetes, almost all type 1 and more than 60% of type 2 have some degree of retinopathy. Incidence of proliferative retinopathy is more in type 1 diabetes mellitus. What are the risk factors? The poor glycemic control, erratic food behavior, no exercise, obesity, and irregular intake of drugs, and inadequate management with the physician or diabetologist, not doing their blood sugar regularly, nor attending the diabetic clinic leads to intensive glycemic control should be there. Otherwise, intensive glycemic control if not there, then the patient will suffer the diabetic retinopathy earlier. So, intensive glycemic control delays the onset and progression of diabetic retinopathy. Good glycemic control, if the blood sugar is under control by repeated and regular checkup, reduces incidence of severe non-proliferative diabetic retinopathy and proliferative retinopathy and need for laser treatment by 45% reduction is there. So you see, the glycemic control is so very important in the direction of reducing the incidence of diabetic retinopathy. What about pregnancy? In patient of diabetic retinopathy, incidence increase by 8% in a pregnant female. 4% with non-proliferative diabetic retinopathy progresses into proliferative diabetic retinopathy. Some has regression of diabetic retinopathy after delivery. So there's a nice news that after delivery, the diabetic retinopathy reduces and regresses. Hypertension. Hypertension is now a comorbidity with diabetes and it is on the rise because of the stress situation in the modern era, having keen competition amongst everybody and rat race for capturing wealth. There is hypertension and the genetic factor and other factors are there. And this systolic is mainly responsible for more of incidence of diabetic retinopathy and uncontrolled hypertension, both systolic and diastolic, leads to progression of diabetic retinopathy and development of diabetic macular edema. Other systemic factors apart from diabetes and hypertension is anemia, dyslipidemia, which is very common nowadays because there is obesity, more of waist circumference. The male and female, erratic diet habit and no exercise, and cigarette smoking associated with increased risk of diabetic retinopathy. Nephropathy, the involvement of the kidney by diabetes. Because of the proteinuria, there is elevated BUN and creatinine. They are excellent predictor of diabetic retinopathy. When a patient is suffering from diabetic nephropathy, then one must see if he is suffering from diabetic retinopathy. That is, it's mandatory to examine by an ophthalmologist to exclude diabetic retinopathy. It is mostly associated in case of moderate to severe nephropathy. Timely treatment of renal disease improves diabetic retinopathy and better response to laser if the nephropathy is being corrected and properly treated by a nephrologist and a physician as well. Cataract surgery may lead to progression of macular edema. What is the pathogenesis? Diabetic retinopathy is one of the largest causes of vision loss worldwide. So that is, for that reason, it's very important. Everybody should know about diabetic retinopathy. And main cause is the biochemical pathways, advanced glycation, protein kinase C, and polyol pathways are the biochemical pathways, and angiogenesis factors like vascular endothelial growth factor and IGF-1 is increased. And difference in genetic susceptibility to the effects of hyperglycemia in the retina may exist among people at different stages of diabetes. Some people of genetic susceptibility suffer more than others. Sometimes racial discrimination is there. Some are more affected rather than the others. So let us go if there is an hyperglycemia. So if there is an hyperglycemia, the retinal blood flow is being reduced and there is growth factors is that is vascular endothelial growth factor and TGF beta is being increased and there is a basement membrane thickness because of the increased vascular endothelial growth factor and there is a vascular occlusion because of the decreased retinal blood flow. There is platelet aggregation, RBC Rulex formation, and there is the leukocyte aggregation and adhesion, and the vascular cell death in the polyol pathways, and advanced glycation end products, and retinal hypoxia is there because of the both vascular occlusion and vascular cell death, which leads to increase of growth factor, that is vascular endothelial growth factor and PGDF, that is increased, and that is PDF is decreased. And that leads because of the growth factors are increased, there is retinal neovascularization, there is increase of blood vessels in the retina. And the microvascular occlusion, what the capillary changes, there is loss of pericyte, thickening of basement membrane, damage and proliferation of endothelial cells. So the picture we have shown, there is occlusion is there and leakage is there and the loss of pericyte is there and the RBC Rulex formation is there and thickening of basement membrane etc. are there. So these pathophysiology of loss of pericyte, thickening of basement membrane, damage and proliferation of endothelial cells leads to the capillary changes required for the microvascular occlusion. These hematological changes, the Rule's formation of RBC. RBC is in a different shape and size, and there is a Rulex formation with the adhesion, there is increased platelet adhesiveness, there is abnormal serum lipids, increased vascular endothelial growth factor, leading to microvascular occlusion, retinal ischemia, and hypoxia, leading to vascular endothelial growth factor. There is AV shunt and capillary dropout and intraretinal microvascular abnormalities there, and neovascularization in the disc and retina and the iris is there. That is being shown in the picture. Here the neovascularization is there, and there is the iris is there. These things, and these are the shunts, AV shunts. So this is in a pictorial presentation. And the microvascular leakage, because of the capillary changes, there is decreased number of pericytes, loss of facial wall integrity, distension of capillary wall because of the vessel wall becoming weak. Therefore, there is outpoaching. There is outpoaching, and these are microaneurysms, the bulging, and the breakdown of blood retinal barrier, and the leakage of plasma constituents. There is intraretinal hemorrhage and retinal edema and exudates. These are the retinal edema and this is the hard exudates. So this saccular outpoaching of retinal capillaries due to pericyte loss is the earliest detectable change. In addition, there is teeny round red dots, initially temporal to fovea. These things are there. In fundus fluorescence angiography, there is early hyperfluorescence with late leakage. That is being shown. There is temporal to fovea, and these are the hemorrhages, intraretinal hemorrhages. These are the dot blood, venous and deep layer, and in inner neural layer. These are the dot blood hemorrhages. And in the nerve fiber layer, there is flame septate at the arteriolar end. Superficial layer, inner fiber layer. These are the flame septate. Soft exudates. What are soft exudates? Small, whitish, fluffy superficial lesions. These are called cotton wool spots. So these are cotton wool spots there. These are indistinct margin and focal infarction in retinal nerve fiber layer, and exoplasmic stasis of blood, post-equatorial retina due to more nerve fiber layer, and in the fluorescent focal angiography, there is focal hypofluorescence. These are the soft exudates. Hard exudates. These are hard. Those are soft. Collection of lipid-filled macrophages. Looks waxy, yellow, distinct margin in outer plexiform layer. Clumps or sarcinate pattern around macula. In fluorescent, fundus fluorescent angiography, there is hypofluorescence. So these are clumps and sarcinate pattern around macula, waxy yellow and distant margin. Intraretinal microvascular abnormalities. Arteriovenous shunt bypassing capillaries, fine red line from arteriole to venule, and dilated vascular channel with newly formed endothelial cells, an immature tight junction. Leakage is found in fluorescent angiography, and tight junction mature, no leakage is seen. And distinct features is intraretinal location, failure to cross major retinal vessels, and absence of leakage on fluorescent, fundus fluorescent angiography. Retinal edema, initially between outer plexiform layer and inner neural layer. Later between IPL and nerve fiber layer, then retinal thickening, then fluorescent angiography, hyperfluorescence due to leakage. And the venous changes are looping, beading, and this is a looping, this is looping, and this is a looping, and the beading and dilatation. So this is a picture where there is the details is given, and the edema is there. Just find out. Optical coherence tomography angiography. We say because in fundus fluorescent angiography we used a dye. Dye is being injected, and because of the dye we see it and delineate the vascular channels, and the different pathologies be determined. But the dye sometimes is harmful. Therefore, there is a newer device, optical coherence tomography angiography is being now followed in some centers, and dye-free analog to retinal angiography using hyperspectral unmixing to retrieve oxyhemoglobin abundance. This oxyhemoglobin abundance is the key factor, and this optical coherence tomographic angiography is a new technique in retinal imaging. It's fast and safe, non-invasive method for detection of neovascularization without side effects of fluorescent angiography. OCT, this optical coherence tomography, measure the oxyhemoglobin in retinal vessels. The sensitivity and specificity still is to be established. This is non-invasive dye, free analog to angiography, imaging with anon scanning, spectral imager, the image mapping spectrometer to test on the abundance of oxyhemoglobin. It can be used to evaluate retinal and choroidal perfusion. This oxyhemoglobin will give an idea, and the vascular integrity in eye, because the neovascularization or the aneurysm, etc., this can be seen and felt. And uses, because it is better, it can be used. It is non-invasive, no dye being injected, it is fast, and no dye-induced side effects. Sometimes there is, because of the dye, there is nausea, vomiting because of the allergy. Sometimes there is pruritus, and rarely, sometimes also it is found in some cases there is cardiac arrest because of the allergen and the seizures, and even up to death can occur. Very rarely, of course. So DCCT and EQPDS trial established that chronic hyperglycemia is the initiating major cause of diabetic tissue damage in the retina. Both the trials have suggested that diabetes is the major cause, and uncontrolled diabetes with uncontrolled glycemic control, uncontrolled hyperglycemia, and association of hypertension all are the major cause of diabetic tissue damage. In the DCCT intensive insulin therapy in patients with type 1 diabetes, A1C of 7% reduced the incidence of retinopathy 76% compared with the conventional therapy. So the insulin reducing in a type 1 patient, the A1C up to 7, then the reduction of retinopathy is around 76% reduced. So how the glycemic control is very important, this signifies. EcoPDS found similar results in patients with type 2 diabetes. Type 2 diabetes is no excuse. The similar glycemic control or early insulin therapy or proper use of oral hypoglycemic agent and proper follow-up and good HbA1c will definitely give a better result and regression of diabetic retinopathy. And the duration of diabetes is also very, very important, and the duration of glycemic control is also to be emphasized. Each 1% of HbA1c was associated with 37% in decrease in development of retinopathy. So how much important is the glycemic control in diabetes? You must know. And the control of diabetes by regular diet and good exercise and good oral hypoglycemic agent or insulin will definitely bring the A1C to nearly normal, and every 1% we can reduce 37% decrease in the development retinopathy. So this is so much important. One must ascertain this. So classification of diabetic retinopathy is non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, diabetic maculopathy, and advanced diabetic eye disease. These are the four varieties. Non-proliferative diabetic retinopathy. These are mild, moderate, or severe. Mild non-proliferative diabetic retinopathy may be any or all microaneurysms may be there, retinal hemorrhage may be there, exudates, cottonwool spots may be there, and no intraretinal macular abnormality may be there, and 5% risk of peripheral of proliferative diabetic retinopathy within 1 year, and 15% risk of high risk proliferative diabetic retinopathy in 5 years. In moderate non-proliferative diabetic retinopathy, there is severe retinal hemorrhages in one-third quadrant out of 4 quadrants. In one-third quadrant, there may be severe retinal hemorrhage or mild intraretinal maculopathy, macular abnormality, and significant venous bleeding in no more than 1 quadrant. And cottonwool spots are there. And 12 to 27% go into proliferative diabetic retinopathy in a span of 1. Severe non-proliferative diabetic retinopathy, the 4 to 1 rule, 1 or more of severe hemorrhage in all 4 quadrants. 1 or more of severe hemorrhage in all 4 quadrants. Significant venous bleeding in 2 or more quadrants, and in moderate intraretinal macular abnormality in 1 or more quadrant. And these cases can go into proliferative retinopathy, 15% cases in a period of 1 year. Classification of proliferative diabetic retinopathy is a mild to moderate or high risk. Mild to moderate proliferative diabetic retinopathy. New vessels on the disc, or the new vessels on the disc. This is the disc, and these are the new vessels, or new vessels elsewhere, but extends insufficient to meet the high risk category. Is the mild to moderate variety. High risk, new vessels on the disc. New vessels on the disc greater than 1/3 disc area. 1/3 of the disc is the disc. Greater than 1/3 disc area. is involved. Any neovascularization with vitreous hemorrhage and NV greater than half disc area, that is new vessels elsewhere, greater than half disc area with vitreous hemorrhage. So this is a high risk. High risk, you're right. Then clinical assessment of neovascularization. New blood vessels around the disc or within one disc diameter, around disc. Mild, less than 1/3 disc area, severe if more than 1/3. And new vessels elsewhere arise from retinal vein or at arteriovenous crushing, superotemporal or inferotemporal area, superonasal or inferonasal area. Mild is less than half disc area in extent and severe is more than half area in extent according to the invasion. It is mild or severe. And about diabetic maculopathy. Involvement of the fovea by edema and or hard exudates and if there is ischemia. Most common cause of visual impairment in diabetic patients is diabetic maculopathy. What is the cause of edema? Edema is due to dilatation of the capillaries, destruction of the capillary wall leading to edema. And the ischemia is due to occlusion of the capillaries. There is hypoxia and microinfarction leading to ischemia finally, leading to infarction. Classification of diabetic maculopathy, focal maculopathy, diffuse maculopathy with cystoid macular edema, ischemic maculopathy, mixed maculopathy, clinical significant macular edema. These are 5 varieties. Focal exudates. This is in rounded structure we have shown here. These are the hard exudates. Circular retinal thickening with hard exudates. These are focal exudates. Next, diffuse exudates. Diffuse retinal thickening with cystoid changes, typical microaneurysms and small hemorrhages. These are small hemorrhages and these are microaneurysms is also there. And obliteration of fovea. And this is the leakage on fluorescent angiography and mild and late phase of diffuse hyperfluorescence. Ischemic, capillary non-perfusion because of occlusion at the fovea on fluorescent angiography. Clinically significant macular edema. Retinal edema within of center of fovea. Hard exudates within center of fovea with adjacent edema which may be outside 500 micrometer limit. And retinal edema, one disc area or larger, any part of which is within one disc, distinct diameter of 1500 micrometer of center of macula. This is 1500 micrometer distance and this is 500, that is 500. Advanced diabetic eye disease, uncontrolled proliferative diabetic retinopathy, causes hemorrhage, retinal detachment or neovascular glaucoma. Hemorrhage, pre-retinal intravitreal. There is either pre-retinal or intravitreal hemorrhage. Retinal detachment is tractional retinal detachment, and finally neovascular glaucoma also can occur. Causes of vision loss in diabetic retinopathy: macular edema, macular ischemia, vitreous and pre-retinal hemorrhage, tractional or combined detachment of retina causes the vision loss. So, how to screen? In patient group of type 1, type 2 or pregnancy, different groups how will do. Recommended fast examination, In type 1, within 5 years after diagnosis of diabetes, once patient age is 10 years or older. In type 1 cases, after the patient is becoming 10 years, after 5 years of the diagnosis type 1, one must examine the eye. Then yearly if retinopathy is present, or if retinopathy is not there, every 2 years if there is no evidence of retinopathy. So every year if retinopathy present, every 2 years if there is no retinopathy. But definitely after 5 years of diagnosis of type 1 diabetes mellitus, one must check the eye. In case of type 2 diabetes mellitus, at time of diagnosis of diabetes, because suppose the patient is diagnosed today, then we must refer to the first diagnosis. Therefore, let us check, because sometimes type 2 diabetes present late to the doctor. Therefore, we do not know how long he is suffering. Therefore, he should be presented to the ophthalmologist for a detailed eye examination to exclude diabetic retinopathy. And yearly if retinopathy is there, and every 2 years if there is no evidence of retinopathy. In case of pregnancy, in pre-existing diabetes mellitus, prior to conception, he must be euglycemic, and during first trimester, try to make her glycemic control, counsel on risk of development and the progression of retinopathy with pregnancy. So during pregnancy, the patient should be under euglycemia as per as practicable. Must follow a diabetologist or endocrinologist or a physician to regulate our blood glucose. Close follow-up throughout pregnancy and for 1 year postpartum. So there is sometimes there is regression of diabetic retinopathy after pregnancy, but anyway, one must follow for 1 year after delivery. Mild non-proliferative diabetic retinopathy, there must be follow-up 6 to 12 months. Mild non-proliferative diabetic retinopathy with macular edema on fundus fluorescent examination and angiography, this follow-up is 4 to 6 months. And mild non-proliferative diabetic retinopathy with critically significant macular edema on fluorescent angiography and focal laser, and 2 to 4 months follow-up is necessary. So close follow-up in the latter cases rather than the preliminary cases. So in the milder cases, one is a little relaxing, but in a severe case, one must have within 2 to 4 months every. And moderate non-proliferative diabetic retinopathy, no macular edema, follow-up 6 to 8 months, plus macular edema on fluorescent angiography and follow-up 4 to 6 months, and plus critically significant macular edema on fundus fluorescent angiography and focal laser, plus follow-up 2 to 4 months. There is a close follow-up should be there in case of severe cases. Severe non-proliferative diabetic retinopathy, where there is no macular edema and PRP follow-up is 3 to 4 months, and plus macular edema on fluorescent angiography, PRP after focal, and critically significant macular edema on fluorescent angiography, focal laser is given. So PRP follow-up every 2 to 3 months. Very closely follow-up is necessary in these cases. Treatment of diabetic retinopathy. Management of diabetic retinopathy depends upon early, aggressive, and consistent control of blood glucose. It is very fundamental that euglycemia, normoglycemia is very, very important to reduce and regress diabetic retinopathy. Regular fundus evaluation is necessary to see the progress. Timely and appropriate management is the hallmark of diabetic retinopathy management. Management of diabetic retinopathy is a good glycemic control, retards progression of severe non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Hypertension leads to risk of progression of diabetic macular edema and diabetic retinopathy. The optimal control of hypertension should be there with different type of drugs and regular checkup of blood pressure. Proper management of diabetic nephropathy with regular consultation of nephrologist to see that the diabetic nephropathy should regress, otherwise this retinopathy will progress. Correction of anemia is essential for reduction of diabetic retinopathy. Smoking plays a great role in augmenting diabetic retinopathy, so smoking should be stopped to prevent and retard diabetic retinopathy. Proper use of statins of managing dyslipidemia is essential point in management of diabetic retinopathy. Early consultation of ophthalmologist is the vital cause of reducing, and regular checkup will also see the progress, and when the ophthalmologist can decide what to do next in different conditions, and also can tell the patient that he must have a good glycemic control, regular BP checkup, and regular lipid abnormality checkup, and the anemia control, etc. And also do the needful at the different stages of the disease. The surgical management is pan-retinal photocoagulation, focal grid photocoagulation, peripheral retinal cryotherapy, in intravitreal triamcinolone acetonide. The steroid is given intravitreal, vitreous inside the vitreous. Intravitreal anti-vascular endothelial growth factor, bevacizumab. Avastin is very popular. It is been given, and vitrectomy in case of hemorrhage, severe hemorrhage. So laser photocoagulation is recommended for eyes with high risk proliferative diabetic retinopathy, severe and very severe non-proliferative diabetic retinopathy in selected cases, and critically significant macular edema. Is laser photocoagulation is the choice. Mechanism, exact mechanism unknown, decreases the production of vasoproliferative factors by eliminating some of the hypoxic retina, stimulates the release of anti-angiogenic factors, also inhibitors from the RP. By thinning the retina, PRP increases oxygenation of the remaining retina and so decreases vasodilatation and endothelial cell proliferation. Scatter laser treatment, high risk proliferative diabetic retinopathy, severe and very severe non-proliferative diabetic retinopathy. The goal is to cause regression of existing neovascular tissue and to prevent progressive neovascularization in future. Laser used argon green diode or ND, green is used. Amount of therapy determined by clinical response. The ophthalmologist decide how much to give. Full PRP is more than 1200 burns of 500 microM size separated from each other by half burn wide at 0.1 second duration in 2 or more sessions. It is avoided in areas of prominent fibrovascular membranes, vitreoretinal traction, and tractional retinal detachment. Laser photocoagulation for critically significant macular edema. There are two types of laser treatment, focal and grid. Focal laser treatment for focal leakage, for local leakage guided by fundus fluorescent angiography. For local leakage, the laser used is argon applied to all leaking microaneurysms between 500 and 3000 millimeter from the center of the fovea. Parameters 50 to 100 micrometer. Spot size and the time is 0.05 to 0.1 second. Endpoint, whiten or darken microaneurysm. This is being seen here. Complications, paracentral scotoma, transient increased edema, choroidal neovascularization, subretinal fibrosis, and scar expansion. Grid pattern laser for diffuse leakage, that was focal leakage, here diffuse leakage, or zones of capillary non-perfusion adjacent to the macula. These are grid. Laser used argon applied to all areas of diffuse leakage or capillary non-perfusion more than 500 micrometer from the center of the macula and 5 micrometer from the temporal margin of the optic disc. Parameters 50 to 100 micrometer. The spot size 0.05 to 0.1 second. Spot spaced at least one burn white the fat. There's a grid pattern, laser treatment, vitrectomy in diabetic retinopathy. Indications: dense, non-clearing vitreous hemorrhage, tractional retinal detachment involving macula, combined tractional and ragamotogenous retinal detachment, diffuse diabetic macular edema associated with posterior haloid traction, recurrent vitreous hemorrhage despite maximal PRP, anterior segment neovascularization with media opacity preventing PRP, and red blood cell induced glaucoma. These are the indications of vitrectomy in diabetic retinopathy. Vitrectomy technique. Vitrectomy: remove as much vitreous as is necessary and safe. Membrane removal or segmentation. Retinal reattachment as needed. Larger burns, one burn wides apart from arcades to periphery. So this is being shown here. Is a vitrector, is the light pipe, and these are the hemorrhages. And intravitreal injection of triamcinolone acetonide for diabetic macular edema. Anti-inflammatory effect is the steroid. The anti-inflammatory effect is there. Contribute to reduction of edema. Increased diffusion by modulation of calcium channels also account for efficacy of corticosteroid in decreasing macular edema. Injection site: inferotemporal quadrant. To avoid drug deposition in front of the visual axis, dose is 0.1 ml, that is 4 milligram. Disadvantage is short duration of action is there. Complications because of the steroid injection is cataract, glaucoma, and ophthalmitis because of the infection, because of steroid induces infection. Intravitreal anti-vascular endothelial growth factor injection, bevacizumab, that is Avastin. Mechanism: binds directly to vascular endothelial growth factor to form protein complex, which is incapable of further binding to vascular endothelial growth factor receptor sites, effectively reducing available vascular endothelial growth factor. Doses 1.25 in 0.05 ml. Being injected. Ranibizumab Lucentis is a monoclonal antibody fragment with affinity for vascular endothelial growth factor A. It has anti-angiogenic property also. And the dosage is 0.5 milligram in 0.05 ml. Aflibercept, that is ALA. Its mechanism is it is a fusion protein consisting of portions of receptors for the vascular endothelial growth factor molecule, vascular endothelial growth factor 1 and vascular endothelial growth factor 2, thereby binding and blocking vascular endothelial growth factors. The dose is 2 milligram per in 0.05 ml. And in summary, the eye examination, there is diabetic retinopathy may be there or no diabetic retinopathy. If there is no diabetic retinopathy, this annual follow-up is necessary for type 2 patients and type 1 patients. And if it is diabetic retinopathy, then we have to find out is it non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. If it is non-proliferative diabetic retinopathy, whether mild diabetic macular edema in the center is not involved or center is involved. If it is center not involved, then laser is there. If it is center involved, then anti-vascular endothelial growth factor injection that we have given, described just now. And if it is proliferative diabetic retinopathy, this is a neovascularization elsewhere, a non-vascularization in the disc. The PRP is required, and if there is a hemorrhage, that is PRP is pan-retinal photocoagulation, and hemorrhage or tractional detachment, it is PPP. For patient hearing, I thank you all, everybody. Thank you very much.